Welcome to the GE Healthcare Pharmaceutical Diagnostics Symposium. Today our webinar is Neurology and Nuclear Medicine, working together for an optimal dementia diagnosis. Our speakers are Professor Valentina Garabotto, who works in the Division of Nuclear Medicine and Molecular Imaging at the Geneva University Hospital and Geneva University. We also have Professor Giovanni Frazzoni, who is head of the Outpatient Memory Centre at the Division of Neurology, again at the Geneva University Hospital and Geneva University. The disclosures for today are that GE Healthcare sponsored this symposium and the speakers received an honorarium for the presentation. And you can see the disclosures for Professor Garabotti and Professor Frazzoni on the slide. Before we get started, we will go over some important safety information.
Important safety information about Vizamyl fludimetamol F18 injection. Product indications and limitations. Vizamyl fludimetamol F18 injection is indicated for positron emission tomography or PET imaging of the brain to estimate beta amyloid neuritic plaque density in adult patients with cognitive impairment who are being evaluated for Alzheimer's disease or other causes of cognitive decline. A negative scan indicates sparse to no neuritic plaques, inconsistent with a diagnosis of AD at the time of image acquisition. A negative scan result reduces the likelihood that a patient's cognitive impairment is due to AD. A positive scan indicates moderate to frequent amyloid neuritic plaques. This amount of amyloid neuritic plaque has been shown to be present in patients with AD, but may also be present in patients with other neurologic conditions, as well as in older people with normal cognition. Vizamyl is an adjunct to other diagnostic evaluations. Limitations. A positive scan does not establish a diagnosis of AD or other cognitive disorder. The safety and effectiveness of Vizamyl have not been established for predicting the development of dementia or other neurologic conditions or for monitoring responses to therapies. Contraindications. Known hypersensitivity to Vizamyl or any excipient, including polysorbate 80. Warnings and precautions. Hypersensitivity reactions. Reactions such as flushing and dyspnea have been observed within minutes following administration and may occur in patients with no history of exposure to Vizamyl. Before administering Vizamyl, ask patients about prior reactions to drugs, especially those containing polysorbate 80. Have resuscitation equipment and trained personnel available. Risk for image misinterpretation or other errors. Errors may occur while interpreting Vizamyl positron emission tomography images. Image interpretation is performed independently of the patient's clinical information. The use of clinical information in the interpretation of Vizamyl images has not been evaluated and may lead to errors. Extensive brain atrophy may limit the ability to distinguish gray and white matter on a Vizamyl scan. Motion artifacts may distort the image. Images should be interpreted only by readers who have completed a reader training program available from GE Healthcare.
So the agenda today is an introduction to the speakers, which we've already done. And the cases presented today are taken from clinical routine and they're part of the AMYPAD program. So we'll just give a brief overview of the AMYPAD diagnostic study. We'll have a look at our case reviews where we include how the nuclear medicine and neurology department work together. And then we'll conclude with some final thoughts. So AMYPAD is amyloid imaging to prevent Alzheimer's disease. It's an ongoing program funded by the EU Innovative Medicines Initiative, IMI, and FBA pharmaceutical partners. And the consortium consists of 9 academic partners, including the University of Geneva, who are presenting today, as well as 3 FBA partners, that's GE, Janssen, and Life. And we also work very closely with the patient organization Alzheimer Europe, as well as 2 SMEs, Ixoco and Synapse. And in an overview of AMYPAD, there's 2 main studies where we're delivering on our objectives. The first one is the diagnostic value study on the left-hand side, and these are where our cases have come from. And the second is a risk stratification study. It's a natural history study. And then combining both of the data from both studies, we actually are looking at quantitative assessment of amyloid PET with a view to monitoring treatment. Now I'm going to hand over the presentation to Professor Frazzoni, who will give an overview of the design of the diagnostic study.
Now, the AMYPAD Diagnostic and Patient Management Study is a clinical trial where we try to test the efficacy of amyloid PET to improve diagnostic accuracy. In this slide, you can see the design. We're supposed to, we have already recruited 900 patients or next to 900 patients, 1/3 with a subjective cognitive decline, 1/3 with mild cognitive impairment, and 1/3 with dementia. They've been randomized to Arm 1, Arm 2, and Arm 3. The study is a naturalistic study. It's templated onto clinical practice. So patients follow the regular diagnostic pathway in all centers, and in Arm 1, amyloid PET is carried out early on during the diagnostic pathway. In Arm 2, early on means as early as possible. In any case, earlier than 4 weeks from first assessment. In Arm 2, amyloid PET is carried out at the end of diagnostic process. Patients follow the regular diagnostic process. They receive a diagnosis based on the regular exams and regular assessment. They're providing a management plan. They're providing medications, and then at up to 8 months from baseline assessment, they receive amyloid PET, and the physician reformulates, revises the diagnosis that was issued in the first place. In Arm 3, the physician can choose whenever the patient will undergo amyloid PET. Earlier on, after 8 months, up to 12 months, never. These are the samples that have been taken part to this study all over Europe, and the primary endpoint of the study is the frequency of etiological diagnosis with very high diagnostic confidence. Our hypothesis is that the number of patients, the proportion of patients with very high confidence, with an etiological diagnosis with very high confidence, would be higher in Arm 1 than in Arm 2. In Arm 3, the hypothesis is that as the program, as the project unfolds and goes on over time, physicians will prescribe amyloid PET earlier on during the process. And we also have a number of secondary endpoints that you can read yourself.
Thank you for this description. And as a nuclear medicine physician, I want to confirm our enthusiasm in taking part to this study and how this has allowed us really to familiarize with the use of amyloid PET in the daily practice. Giovanni, I don't know if you want to describe.
Yes, thank you, Valentina. These are real cases. These are cases taken from AMYPAD, from the AMYPAD project. And let me emphasize and remind everybody that these are real life patients. They're not special in any way. They're regular patients with a subjective cognitive decline, MCI, and dementia. This first patient is a 74-year-old person who has been working as a blue-collar worker until age 40. After age 40, he has been at the charge of social welfare due to orthopedic problems. His physical health is relatively good, but he had a number of surgical interventions to the back and to the hips for orthopedic reasons. He has no risk factors, no cerebrovascular risk factors. He has a psychiatric history. He's been depressed, he has had a number of depressive episodes in the past. The first one when he was 30-year-old, the last one 10 years before assessment. He complained memory loss, which is confirmed by his spouse, his ex-spouse actually. Apparently, he is fully self-sufficient in daily life, in daily life activities. He's not taking, despite the psychiatric history, he's not taking any medication. This is his neuropsychological assessment, the detailed neuropsychological assessment However, before undergoing the neuropsychological assessment, Valentina, he underwent a neuropsychological screening. He had he scored 27 out of 30 on the MMSC, or 24, depending on how you compute the score. He scored 9 out of 10 on the clock drawing test, which is not shown here, and he scored 9 out of 9 on an episodic memory test. Despite his psychiatric history, he scored a 3 out of 21 on the Hamilton Anxiety Scale and 1 out of 21 on the Hamilton Depression Scale. In the slide, you can see the MMSC, and you can see the first part of the neuropsychological assessment, where you can see that language is relatively preserved. You can see a number of N's, which stands for normal, a few LIM, which is limit in French, which is low range normal, but still normal. If you go to the next slide, in this slide, you can see that verbal episodic memory was very low, and it did not benefit from cues. And executive functions were only mildly affected. If you can go to the next slide.
Sure. Here you can see the MR, right, Giovanni? So
not yet.
It should come up in a minute. And in the meanwhile, we can say that this clinical picture is fairly typical. A prevalent memory impairment, would this point to what as your first diagnostic hypothesis?
This is amnestic mild cognitive impairment. And this is his MRI. MRI for a 74-year-old person. You can see some very mild atrophy on to the right, slightly more accentuated to the left. The ventricles are slightly enlarged, but there seems to be no cortical atrophy, and there's a few white matter hyperintensities, not with no pathologic meaning. So the diagnosis of this patient is MCI, the neuropsychological profile, which is quite typical for Alzheimer's disease, with a severe and clear impairment of memory, was allowed to provide a diagnostic confidence of 80%. This diagnostic confidence is not enough for most physicians to disclose the diagnosis, but it's a starting point. This patient fulfills appropriate use criteria for amyloid PET. At least this is what it seems to me, Valentina. What do you think?
Yeah, indeed, because it's a situation in which you have your hypothesis. It's in a way strong, but I mean, it's still an MCI. Not everything is coherent, so it's typical. It's the typical situation in which, since 2013, we're convinced that amyloid PET could have an added value. And this is what we did. I mean, this was a patient in arm 1, so he was able to benefit of amyloid PET right away. And actually, you see here the images of the amyloid PET overlaid on a standard MR. And I'm sure that my fellow colleagues can agree with me that the rating of this amyloid PET is negative. You see that we saturated the image in a way to have the maximum. In the pons region, you see that in the whole brain from bottom to the top, we can well identify in the temporal cortex and the frontal, temporal, and then parietal cortex, a nice, let's say, delineation of the signal, which is limited to the white matter with a preservation of weak or no binding in the cortical areas. I'm showing you here the axial view, which is the view which is preferred for the rating of the majority of the regions, so frontal, lateral temporal, temporal occipital, of the striatum. For the posterior cingulate and precuneus, it would be important to have access also to the sagittal or the coronal view that would well show in this case that the two hemispheres are well separated, and so that there is no cortical deposition in this region either, that we know is, together with the frontal basal region, one of the first region of deposition. So this image, in this case, can well exclude the presence of amyloid pathology and thus exclude an Alzheimer's disease as etiology of this mild cognitive impairment. Do you agree?
Valentina, any chance that this is a false negative?
I mean, false negative are very rare. There has been multiple studies on flutemetamol and on other amyloid traces that have tested the performance of visual reading across multiple readers against neuropathology as gold standard, so data that are very solid. And the cases for false negative are very limited and mainly in cases exhibiting a very important atrophy. We've seen from this case, from his individual MR, that this patient does not exhibit a major atrophy throughout the brain. So there's no reason to suspect this is a falsely negative scan.
Good. So we are confident that this is a real amyloid negative patient.
Yeah. So how this impact your reasoning, Giovanni? What do you think?
Well, this patient was, after a negative amyloid PET, Alzheimer's disease is ruled out with very high confidence. So the MCI etiology, this is still an MCI patient, but we know that at least between one third and one half of MCI patients do not have AD pathology. They have something else. This something else can be anything between depression, toxic insult of the brain due to alcohol abuse or drug abuse, or non-Alzheimer's co-pathology, non-Alzheimer's neuropathology, among which TDP-43, tau isolated tau pathology, such as in part of primary tauopathy, or alpha-synuclein, or a combination of all of them. So the final diagnosis was MCI, not due to AD, with a relatively high confidence of 85% that it's not AD. It's not, it used to be before amyloid PET, it was 80% AD. Now, the physician regarded this as 85% as non-AD. Probably this is even an understatement, an underestimate, because as you said, the false negatives are very low. One might contend that this 85% should be 95%. In any case, at follow-up after 14 months, the MMSE was still stable and the patient was still self-sufficient. And this is exactly what the literature tells us about non-Alzheimer's amyloid negative MCIs. They are stable. Even when there's in many cases, we're not able to pinpoint one precise cause. But what we know from the literature and what this patient confirms is that these are conditions that do not progress. Or if they progress very slowly, and most times they're not accompanied by disability, which is, of course, of huge relevance to the patient.
Could we say that the fact that the patient had his amyloid PET 1 year earlier, ultimately, his follow-up allowed you to reassure him and gaining 1 year of, in a way, reassured time?
Absolutely. This is absolutely the case. The patient was already reassured after amyloid PET, and the reassurance was confirmed after 14 months with even greater confidence.
Would you prescribe medications for these patients?
No, certainly not the usual cholinesterase inhibitors, not those medications. One might go for milder nootropics, milder cognitive enhancers.
And well, we can discuss it also later on other cases, but what is overall the perception of the patient having to, on the way, undergo these procedures that might look a bit complicated, a bit, radioactive as well, but at the same time, receiving these sort of information? What is the patient's experience in these cases overall?
Well, in general, patients accept PET scans without raising a eyebrow. Rare, occasionally, indeed, occasionally, we have patients complaining about radiations, but once you explain that the amount of radiation is equivalent to the background radiation that everyone absorbs in one year or 18 months, well, people are usually very reassured. Of course, there's occasional exceptions. You have exceptions all the time anywhere.
Okay, well, thank you very much. I think we're ready then to go on for a second example. Yep. In this case, it's a patient, yes, indeed, taken by arm 2. So he had to wait the 8 months that you've seen presented in the scheme of the study to get his amyloid PET. I'll let you further discuss it, Giovanni.
Yes, this is a 73-year-old person, a man, again, with a high education background. He has a university degree. He has, again, a negative family history. He is a widow since 3 years. He has plenty of cerebrovascular risk factors. He has diabetes, hypercholesterolemia, and high blood pressure. And he takes drugs for all of them. He's also some psychiatric background. He's been followed by a psychotherapist, apologies, for 10 years, following a depressive episode that took place until 2-3 years ago, about 2-3 years before assessment. The onset of symptoms dates from 3 years before assessment, right after the death of his spouse. He complained difficulties in concentration. Not real forgetfulness in terms of difficulty recording events, which is what would be typical for an Alzheimer's patient, but more like attention forgetfulness and difficulty in concentration. He was fully self-sufficient in his daily life. Despite he was living alone, he was fully self-sufficient. And neurological exam was also non-contributive. He had just a mild senile tremor. You can see in this slide the MMSE was 27 out of 30 with pathological scores in the domains that you can see: verbal episodic memory, non-verbal memory, attention executive function, and verbal fluency. And if you can go to the next slide, here you see the MMSE, which is 27 out of 30. Some mild problems in the naming, in language. Writing is okay, calculation is okay, visual constructive structure is okay, which relies on right hemisphere function. Ideomotor apraxia is okay. Spatial and visual nausea is okay. Working memory, despite his complaining of concentration problem, working memory is fine, while verbal episodic memory is impaired. And also non-verbal episodic memory. Rappel différé des figures du CERAD is a non-verbal test of non-verbal episodic memory. And episodic and executive functions are also somewhat impaired. So this is an amnestic MCI, amnestic cognitive impairment, multiple domain, with in addition to memory, there's language impairment and attentional executive impairment. As you can see here, there's some medial temporal atrophy to the right. If you compare with the previous patient, it's more accentuated than in the previous patient, while to the left, there seems to be no atrophy. But one side, we know that one side is enough to raise suspicion. The ventricles are mildly enlarged, but this is not beyond what would be expected for age. Cortical atrophy is, there's no cortical atrophy. And there's no parietal atrophy as well. And hyperintensities are again very mild and clinically not significant. Next slide. Good. So at baseline, the patient was included as a dementia patient despite the relatively mild neuropsychological profile, because the physician was placing a lot of emphasis on some difficulty that the patient seemed to report on managing finances. It was harder to evaluate, harder to check, hard to verify, but the physician felt that it was likely that this patient had an impact on daily activity. So he was classified as dementia with etiology undetermined, and he seems to fulfill appropriate use criteria for amyloid PET, but this is a more like a question that I'm asking you, Valentina.
Yeah, it does. Again, what would enter in the appropriate use criteria is that we cannot say that this is a probable AD, because despite the clinical, the neuropsychological profile is there, judgment of the physician is still that, I mean, there are no enough elements. The atrophy we commented is there, but it's still mild. So overall, and seems disproportionate in comparison with the clinical picture. So overall, this would fulfill the criteria for amyloid PET. Given that in the study, he was in arm 2, so he could not undergo an amyloid PET for the first 8 months, an FDG was requested in order to contribute and clarify the etiology. You see here the result, the FDG PET images normalized to the standard template, and you see overlaid in green the areas that are 2.5 standard deviation below what's observed in the normal distribution. You see that this FDG PET is pathological due to a reduction of metabolism in the anterior, but also the posterior portion of the temporal lobe, and less, but still present in the parietal lobe. Exclusively on the left, the distribution we observe is pathological, so one could say that this FDG PET is in favor of a neurodegeneration, but the strong asymmetry and the complete preservation of posterior cingulate and precuneus region brought us to conclude to a result that was possibly evoking a disease in the frontotemporal lobe degeneration spectrum on the basis of the imaging itself, without being able to exclude an Alzheimer's disease as etiology because of this parieto-temporal distribution. So overall, the FDG PET in this case added an element providing a proof of a neurodegeneration, but could not, let's say, conclude definitely on the etiology that was linked with neurodegeneration. So when it was a time, we finally went on with amyloid PET, and in this case, the amyloid PET, as you see, is clearly positive. So the contrast between the white matter distribution and the gray matter distribution is completely lost. The gray matter has focal areas of uptake, as you see, for example, in this left frontal area, or in this posterior cingulate precuneus area, still on the left, that are as intense as the white matter binding. And you also have positivity in the striatal region. You see that this area between the thalami and the frontal white matter is not preserved, is not a free space. So overall, this is a clearly positive amyloid PET image.
Okay, Valentina, would it be fair to say that FDG-PET was equivocal because on the one hand, there was no posterior cingulate hypometabolism, which would not go for an AD diagnosis, so that would be against an AD diagnosis. On the other hand, there was the parietal hypometabolism, which would be in favor of an AD diagnosis. So there were the two contrasting findings that were that made such that the FDG-PET was finally not conclusive. Would that be fair to say that?
Yes, it is right. And it was an FDG-PET which was not typical for either one or the other condition. Plus, it's true that the patient didn't have the clinical picture of a frontotemporal dementia, right? So in this case, also when the imaging result is inconsistent or not consistent with the first clinical hypothesis, it's always difficult in a way to interpret. I mean, it has to be interpreted with care. But in addition, as you point out correctly, I mean, the parietal involvement is not something that we would expect in a language where, let's say, a form of a frontotemporal dementia. And so this FDG-PET was pathological clearly, but ultimately non-conclusive for the etiology.
Good. So at the end of the amyloid PET process, he received a diagnosis of dementia due to AD with a relatively high diagnostic confidence, not terribly high, which is in line with the notion that amyloid PET, a positive amyloid PET pushes less in favor of an AD diagnosis than a negative amyloid PET pushes against an AD diagnosis. This is why for the previous patients, I was suggesting that the diagnostic confidence of 85% for a non-AD pathology was an underestimate. It should have been 90 or 95%. Would you agree about that, Valentina?
I do agree. And what we're showing here are really the ratings that are made by different raters across the different centers. In this case, these are all studies performed in Geneva, but there are multiple really, raters in your group. And so, of course, the scoring of the diagnostic confidence as also, I would imagine, a part of individual appreciation. What do you think about it, Giovanni?
Yes, indeed. Yes, indeed. Diagnostic confidence as a measure is intrinsically subjective. We all, as clinicians, we all share the same basic notion, the same representation of what a high confidence diagnosis is, but of course, there's a huge subjective variability.
So as Giovanni said at the beginning, these are really cases that we selected among the cases we have in AMYPAD in order to show you different uses across the two different arms of the study, but with no specific interventions. Of course, the data are the data collected within the study. So as you see, some interpretations still remains for the clinical stage or for the 5% changes in diagnostic confidence. We can go on with the third case, if you want, Giovanni. He's again a patient coming out from arm 2, an older patient who's compared with the others.
Yes, this is an 82-year-old patient who has been who was a blue-collar worker during his professional life. He retired at 65, 66 years. He's living with a partner. He has a daughter. Family history for dementia is negative. Physical health is pretty good. He's obese, slightly obese, but overall physical health is pretty good. In terms of psychiatric terms, he's anxious by personality, but no psychiatric history. Onset of symptoms, of memory symptoms, is since about a couple of years. with forgetfulness of episodic forgetfulness. This seems to be the typical forgetfulness of events, of life events, of recent life events, and slowly progressive. In this case, we have some disability, some loss of function of daily activities. His partner has been forced to take on administrative business, the payment of invoices, the domestic invoices, and he needs some help to take medications. The MMSE is already pretty low, is 20 out of 30, with the deficits in verbal and nonverbal memory, executive function, and attention, and language. If you go to the next slide, language is affected. Idiopathic apraxia is absent. Nausea, visual nausea is preserved, and working memory is also preserved. If you go to the next slide, episodic memory is clearly almost at floor level. It's very, very poor. There's very little trace that can stick into this person's brain. And executive functions are also pretty impaired.
In this case, we have only non-verbal episodic memory because based on these results, you couldn't administer a verbal test.
Right, thank you. Yes, thank you for reminding me that. Yes, he was so impaired. So if you go to the next slide, by the way, neurological exam was normal. The baseline diagnosis was dementia with probable AD etiology with a pretty high diagnostic confidence, typical hippocampal profile, neuropsychological profile, and apparently this patient with such a high level of probability for AD would not fulfill appropriate use criteria for amyloid PET. Valentina, is that right?
It's right, because I mean, your clinical judgment plus the elements that were collected from the neuropsychological profile are already, let's say, in favor of an etiology, and thus suggesting that no additional investigations are needed. One could also recall that based on the profiles, on the countries, for example, an age limit of 80 is put in order to justify additional investigation. So a patient of 82 wouldn't be eligible for this. We could do an amyloid PET in this case. So when we saw the amyloid PET results that we could offer to this patient within the study, we finally saw that the result was surprisingly negative, despite the strong clinical conviction that on the basis of the neuropsychological profile and of the history, this was an Alzheimer's disease patient. As we discussed previously, this amyloid negative scan can reasonably exclude this etiology. This scan is negative, as you can see in the summary slide. So the distribution of the tracer is limited to the white matter. There is no gray matter deposition in any of the key regions, nor in any of the 5 cortical and subcortical regions. The border is well preserved everywhere. So for this finding is of particular relevance given the high clinical conviction at the baseline, given the age. We know that at 82, incidental amyloidosis might occur, but this did not happen for this patient. So as Giovanni has discussed previously, clearly in this case, we can, the patient is a demented patient, but the etiology that was considered at baseline and 3 months of a typical Alzheimer's disease origin goes to a dementia not due to AD with a high diagnostic confidence, with a 90% diagnostic confidence. So the clinician is convinced on the basis of this result that we can rule out Alzheimer's disease. Or first, I have one question for you. So we concluded case 3. We see that, I mean, you started with a strong conviction that this was an Alzheimer's disease, 86 years old patient, and now you find an amyloid negative scan. What does it change? What do you do now that you would do differently as with the information you had before?
Yes, well, when you have a patient with dementia who is also amyloid negative, again, this is a dementia. When you have dementia, you always have a neurodegenerative disease behind. Once you have excluded all the secondary metabolic and blah, blah, there's a neurodegeneration behind. However, as I said, even for the dementia, the non-amyloid positive, or well, the amyloid negative neurodegenerative dementia have a slower course. Even the amyloid positive dementia, in other words, even Alzheimer's disease in the old age are generally slower than the younger age. To give you some to give you some benchmark, an 80-something-year-old patient is expected to lose about a couple of points of the MMSE per year. A patient at 60 years of age is expected to lose 4.5 MMSE points per year. So the progression of dementia is more than twice as faster at younger age than an older age. In the case of a non-Alzheimer's, of an amyloid negative dementia, the progression is even slower. One might also consider of not giving medication, but in any case, in this patient, the anti-Alzheimer's medications, strictly speaking, are indicated. Strictly speaking, are indicated because the clinical trials whereby the medications were approved were carried out in a mixed population, in a population that was 2/3 Alzheimer's and 1/3 non-Alzheimer's dementia.
This was well before our amyloid PET, right?
This was well before our amyloid PET, yes. We know it in retrospect. In retrospect, we know that those guys that were used to register the anti-Alzheimer's drugs, they were mixed. It was a mixed population, 2/3 Alzheimer's, 1/3 non-Alzheimer's. This guy, the guy that we have here now, is part of the 1/3. So technically, we can prescribe anti-dementia medication to this patient. But if the patient has some even milder contraindication for not taking anti-dementia medication, such as heart disease or respiratory disease, you feel much more comfortable not to give him, not to prescribe them to him, because he's amyloid negative. And this tells you that he would progress slowly anyway.
Would you give different, in a way, communicate it differently to the family? Probably yes. You would say that anyway,
yes.
He's on a more benign course. So,
Exactly. This is exactly the case.
Oh, happy to see that it helps. So, and so we can go on with the last case. So this is a patient that was, again, included in the study in the arm 2. So he had to wait 8 months in order to undergo his amyloid PET. But as compared with the one we just discussed, he's much younger, he's 65, and he's not demented, but he has a mild cognitive impairment. So he's still fully autonomous. I won't show you the images here, but he's done an MR that was negative, non-contributive in a way, did not show or contributive in excluding the presence of a neurodegeneration. The MTA, the mesial temporal atrophy score, visual score, was 1, so still within normal ranges. The CUDAM, that's a scaling for parietal atrophy, that was 1, so mild, limited parietal atrophy. And the ARWMC, this is the age-related white matter changes. So in a way, the presence of these white matter abnormalities that indicate vascular co-pathology was very low, 3 out of 30. So the MR did not identify focal atrophy or a vascular pathology that could point to a neurodegenerative or a vascular etiology for this disorder. The neuropsychology, on the other hand, was quite typical. because the patient had an amnestic and multi-domain executive profile. I will show you the neuropsychological results as you've seen for the other patient. As a summary, you can see here that the mini-mental was at the inferior limit for norms, so 26 out of 30, but there were pathological scores in multiple domains. So you see here the results of the screening. There was mainly an issue in orientation or in the memory component. But then you see the language or apraxia or nausea was still preserved and normal. But when we do go to the memory test, we have a pathological results both for verbal and non-verbal episodic memory. So the cued recall in particular was pathological and below the norms, while executive functions or attentions were preserved with some minor with performances that are lower than the normal ranges at the trail making. So with this picture, so the normality of the MR plus a neuropsychological performance that was below norms was considered by the clinician of mainly a psychiatric origin, where anxiety was considered the primary, let's say, reason for these pathological neuropsychological performance, despite given or considering the normal results of the imaging test. But the diagnostic confidence in this conclusion was fairly low, as Giovanni has commented already. I mean, we know that in MCI, of course, there is a risk of having an underlying neurodegenerative condition, and thus the neuropsychological profile alone plus MR cannot conclude per se in the presence or absence of a neurodegenerative disorder for causing this syndrome. So we are fully in the appropriate use criteria for prescribing and performing an amyloid PET. That has been done in this case. And as you
yes,
see,
what Valentina, what the reasoning of the physician was, this patient smells psychiatric, but I suspect that there's something else down there.
okay. Well, and then as you were saying before, for the dementia, there is always a neurodegenerative origin, but for the MCI, it could not be. It could be that it's not, right? For the MCI, also, let's say a benign psychiatric condition could be fully responsible for pathological scores in multiple domains.
Absolutely. There's plenty of patients with psychiatric conditions and not necessarily schizophrenia or bipolar. Even personality disorder can be associated with low cognitive performance, and they can be, but they're not protected by from neurodegenerative diseases. So they can very well have a neurodegenerative disorder as well. So once a patient, if you find a patient with a psychiatric condition in the history, you should not hurry on labeling the cognitive impairment as a psychiatric. It can be, but sometimes it's not.
Yeah, and well, we see well in this case that the, let's say, the suspicion of the clinician that there was also another underlying condition was well formulated, because you see here that his amyloid PET is clearly positive in multiple regions: front, basal, lateral temporal, parietal, posterior cingulate, and precuneus. We can see it in this slide, but I mean, of course, we should review it in sagittal and coronal views. And you can also see that also the striatum has positive amyloid deposition in this case. So it's a fully positive amyloid PET. When we told you this, so that this amyloid positive scan was positive, the interpretation of the case changed quite dramatically. So he passed from a 70% interpretation that was possibly not an Alzheimer's disease, but rather a psychiatric origin, to a 95% confidence of an MCI due to AD. This information.
Valentina, would you care to comment on the reason of this very high confidence? We just commented that a negative amyloid PET militates strongly in favor of a non-Alzheimer's condition, while a positive amyloid PET is not so strongly a proof of amyloid of an amyloid cause, of an Alzheimer's cause. It's a proof of presence of amyloid, but not that amyloid is the cause of the cognitive impairment. Why this high diagnostic confidence? Would you like to speculate?
I'm convinced that the age of the patient played a role in this level of change. So the patient is 65. We know that amyloid incidental amyloidosis might occur also at early age, but it's definitely less common. So this early onset plus a very strong positivity on the images, I think that's possibly what's played here the relevant role for this very high confidence. What do you think?
Yes, I believe that's absolutely the case. I fully agree. There's plenty of patients age 85 who have amyloid in their brain and no cognitive impairment. In other words, they are so early on in the amyloid process that amyloid is not the culprit. Amyloid is not causing anything. And you can have, as well as you can have cognitively unimpaired person, you can also have person with cognitive impairment to other causes and be incidentally amyloid positive. But when someone is young, it's extremely rare to have incidental amyloid positivity at 65. And this patient was 66 at the time, 65. So it's extremely infrequent. So in a patient with MCI at 65 years of age, with MCI and amyloid positivity, the MCI is very, very likely due to the amyloid cascade. So there's neurodegeneration associated. It's not psychiatric. It's not a consequence of the psychiatric condition, but there's amyloid-related neurodegeneration behind.
I imagine for this patient and his family and caregivers also a major change with this result. I mean, on a way, bad news, but on the other hand, possibly, relevant information to plan. What do you think?
Well, yes, of course, it's relevant information. It's very relevant information. Of course, it's not a change for the better. It's a change for the worse in a way, but at least most of patients tell you, and families, at least now I know. Many patients, many caregivers tell you, I knew that there was something more. I knew, and nobody was listening to me. Now, you see, doctor, you confirmed what I've always been knowing, what I knew all the time, and the exams that you did confirmed that I was right.
Yeah, I see that this patient has a follow-up, so we've been able to evaluate him 24 months after the inclusion, which was, possibly at the time of the PET, ultimately, that was done as in arm 2, 8 months after inclusion. And there's also there's already the possibility to see a decline. So we had a Mani-Mental of 26, now it's 24. And there was also the prescription of a drug. So the positivity of the test also associated with, consequences on planning as well as on medication prescription. An MCI for which the most likely etiology is a psychiatric, of course, would not undergo prescription of an anti-Alzheimer medication, while now the positivity of the amyloid PET fully qualifies him for this. So I would say that with this case, we can wrap up the concepts that we've been able to discuss together with Giovanni, and on these 4 examples. We're both fully convinced that amyloid PET has a relevant impact on clinical reasoning and diagnosis, and we hope we've been able to show you a few examples of this. This impact is there both for patients with MCI and for patients with dementia, with different considerations and different backgrounds, but in both phases of the disease, the results on amyloid positivity and negativity has an impact. It really occurs both in amyloid positive and amyloid negative cases, because as we've discussed, the consequences are in one case to rule in Alzheimer's disease, if possibly the clinical picture was not so strongly in favor of, or to rule out it in amyloid negative cases. And also selected non-appropriate use criteria indications might benefit from it. There is a constant review process for diagnostic criteria and for appropriate use criteria for the different biomarkers in this field. As Giovanni has commented, we know from clinical trial populations that even patients that have a strong, even patients for which the clinician is strongly convinced that the etiology is Alzheimer's disease might be amyloid negative in a relevant proportion. So these patients in which the clinical profile is very strongly in favor are not necessarily patients that won't benefit from an amyloid PET. There are studies out there showing the impact actually of amyloid PET both in patients within and without the appropriate use criteria. So this is a literature that is really evolving. I hope we've been able to also showcase you that the multidisciplinary discussion of the clinical neuropsychological profile, but also biomarker result is necessary and very useful, and let's say important and enriching both for the clinician and for the biomarker expert. We're also all both convinced that data in AMYPAD will greatly contribute to further understanding what's the role of amyloid PET in this field, and will greatly contribute to defining evidence-based recommendations for its use and for its implementation into clinical practice. And with this, I would like to thank you for listening and for your attention.
Important safety information about Vizamyl, flutamidamol, F18 injection continued. Contraindications: known hypersensitivity to Vizamyl or any excipient, including polysorbate 80. Warnings and precautions: hypersensitivity reactions. Reactions such as flushing and dyspnea have been observed within minutes following administration and may occur in patients with no history of exposure to Vizamyl. Before administering Vizamyl, ask patients about prior reactions to drugs, especially those containing polysorbate 80. Have resuscitation equipment and trained personnel available. Risk for image misinterpretation and other errors. Errors may occur while interpreting Vizamyl PET images. Image interpretation is performed independently of the patient's clinical information. The use of clinical information in the interpretation of Vizamyl images has not been evaluated and may lead to errors. Extensive brain atrophy may limit the ability to distinguish gray and white matter on a Vizamyl scan. Motion artifacts may distort the image. Images should be interpreted only by readers who have completed a reader training program available from GE Healthcare. Radiation risk. Like all radiopharmaceuticals, Vizamyl contributes to a patient's long-term cumulative radiation exposure and cancer risk. Ensure safe handling to protect patients and healthcare workers from unintentional radiation exposure. Adverse reactions. The most commonly reported adverse reactions in clinical trials were flushing, 2%, increased blood pressure, 2%, headache, 1%, and nausea and dizziness, 1%. Drug interactions. Drug-drug interaction studies have not been performed in patients to establish the extent, if any, to which concomitant medications may alter Vizamyl image results. Use in specific populations. Pregnancy. All radiopharmaceuticals, including Vizamyl, have potential to cause fatal harm. There are no available data on Vizamyl in pregnant women to evaluate drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes. Advise women about the potential for adverse pregnancy outcomes based on the radiation dose and gestational timing of exposure. Lactation. There are no data on presence of flutamidamol or its metabolites in human milk. The benefits of breastfeeding should be considered along with the mother's clinical need for Vizamyl and any potential adverse effects on the breastfed child. Because many drugs are excreted in human milk and there is a potential for radiation exposure to nursing infants, advise a lactating woman to interrupt breastfeeding and pump and discard breast milk for 24 hours after administration to minimize radiation exposure to a breastfeeding infant. Pediatric use. Vizamyl is not indicated for use in pediatric patients. Geriatric use. No overall differences in safety were observed between older and younger subjects. Overdosage. The clinical consequence of overdosing with Vizamyl has not been reported. It is unknown whether or not flutamidamol is dialysable. The major risks of overdosage relate to increased radiation exposure and long-term risk for neoplasia. In case of overdose of radioactivity, hydration and frequent urination should be encouraged. Prior to Vizamyl administration, please read the full prescribing information for additional important safety information.